Hi, Mike Gibson, Ziad Ali, and we're talking about the Lumion 4 results. Talk to us a little bit about what you did, Ziad, why you did it, what you did, and what you found.
Hi, Mike. Thanks so much. Appreciate you taking the time to interview with me. So, as you know, OCT guided PCI is gaining traction. It's a higher resolution imaging modality compared to intravascular ultrasound. And we proved over a series of trials in the ILUMIEN series of trials that OCT could get us to the same minimal stent area as IVUS, but could lead to the least number of untreated procedural complications. So ultimately, compared to angiography, we could get a bigger stent expansion with less malapposition and less major dissection. So we thought, can those benefits and the higher imaging resolution translate to a better clinical outcome? So we designed ILUMIEN 4, which was the largest global single-blinded randomized controlled trial ever conducted in intravascular imaging. It was 2,487 randomized patients, one-to-one to OCT guidance versus standard of care angiography guidance. In the OCT guided approach, we used a specific algorithm to help the operators optimize their PCI, really based on this concept of MLD max that you've heard as being around. So morphology, lesion, and morphology, length, and diameter for the pre, and then to optimize with medial dissection, apposition, and expansion. One of the special things about ILUMIEN 3 was that every patient, irrespective of which arm they were in, had a final OCT. In the angiography arm, they had a final blinded OCT. And the reason we did that is all of those things that we worry about, like edge dissections, tissue protrusion, malapposition, we would finally be able to determine what leads to an event and what can we leave alone.
So you
Because
kind
as
of
you know,
turned the module or the console around, and the tech did it, but the operator couldn't see.
exactly. In only 8 patients did we have a protocol violation where the operator acted on the final OCT.
Mhm.
We had 2 primary endpoints. The first endpoint was a primary imaging endpoint to show that actually OCT got you a larger minimal stent area. The reason we thought that was a meaningful endpoint is, as you know, all of the randomized controlled trials to date suggest that the minimal stent area is the most meaningful predictor of long-term clinical outcomes after imaging guided PCI. So we did that. And then we had a 2-year target vessel failure rate, which was a composite of cardiac death, target vessel MI, and ischemia-driven target vessel revascularization. So, to the results. So, the first thing that we found was that OCT was highly effective in increasing the minimal stent area. It actually increased the minimal stent area by 0.36 millimeters squared. We also found that OCT reduced the incidence of major malapposition, major dissection, major tissue protrusion, and focal geographic miss. So, what we can see, we could treat. OCT also led to an increase in stent expansion, both mean and minimal, and an overall acute procedural success that was better. When we went to the 2-year target vessel failure rates, we did not find a difference in the 2-year TVF rates between angiography and between OCT. What we did see was very similar hazard ratios to the previously published studies in IVUS for both cardiac death and target vessel MI, but we found, interestingly and quite contradictory to previous studies, we found an almost identical level of ischemia-driven target vessel revascularization. We did find a very meaningful and robust reduction in stent thrombosis using OCT with a hazard ratio of almost 0.35. And we also found that OCT led to the least number of angiographic core lab adjudicated complications. So not only was the procedure to perform OCT safe, but OCT guided PCI led to the least number of complications. We did find also that, just like in all the other studies, that the minimal stent area was the primary driver of efficacy in both groups. So the bigger your stent area, the better off you did. And overall, Mike, that was a summary of what we found in ILUMIEN 4.
When I was young, Rick Kuntz and I, we're old guys now, but kind of created the bigger is better paradigm. And that's where all the late loss and all those terms come from the original analyses. Bigger was better, and here, bigger is better as a surrogate yet again. But it didn't translate into clinical outcomes, which is, I think, I got to tell you, I was surprised. So I think most people want to know, Zed, why was that?
Yeah, so there's a couple of theories. I have to say that right on the top of the list, I would say that COVID likely had a major impact on the trial. And one of the things that I learned as a trialist running my first global trial on a large scale, Mike, was that behaviors between geographies are very different.
Yes.
So, for example, in India, for you to go back for chest pain to see your doctor is extremely uncommon. So, those patients most often present with myocardial infarctions or cardiac death. And what I learned is that ischemia driven target vessel revascularization is a behavior more than an endpoint.
Mm-hmm.
You seek attention.
Mm-hmm.
And that was definitely impacted by COVID.
Mm-hmm.
And you can remember in 2020, remember our trial spanned from 2018 till 2020. And during those 2 years, we were right in the middle of the pandemic, and getting access to healthcare for elective procedures for angina was extremely difficult.
Yeah.
I feel like there was a contribution of biasing towards the mean.
Mm-hmm.
That, both groups, whoever had angina, got it managed medically, couldn't get to the hospital, realized it wasn't going to kill them, and they moved on. That
Mm-hmm.
was number one. The second thing that was meaningfully and appreciably different was that the stent sizes, post dilation use, and the atmospheric pressures used in the angiography arm of ILUMIEN 4 were exceptionally high. So
Mm-hmm.
the operators who are now imaging trained
Mm-hmm.
use bigger stents. They
Mm-hmm.
use bigger balloons. They use higher pressure. And that learning curve that they may have gotten previously, I think, translated to a point where the minimal stent area mean was already so big that that magnitude of benefit probably didn't translate to IDTVR.
If I had to guess, I bet that's the biggest issue. I mean, older operators like me who don't do as much intravascular imaging, I'm doing more. I, tend to say, all right, well, then it looks like I need to I need to go up by a quarter size on many of my lesions. So the control group may have overperformed because of that adaptation. Well, Zed, what's the take home message for operators out there?
I think there's a number of key messages. One is that OCT does what it says in the box. It can see what your eye cannot, and it can help you fix it. OCT will get you a bigger minimal stent area. In this study, it didn't reduce ischemia-driven target vessel revasc, but it probably impacts, given the hazard ratios, both cardiac death and target vessel myocardial infarction. But there is a very meaningful reduction in stent thrombosis. And I think, Mike, as an operator, the most devastating consequence of PCI is stent thrombosis. And where we may not have met the primary endpoint in terms of target vessel failure, as a composite of safety, which would be cardiac death, TVMI, and stent thrombosis, this is a very meaningful outcome to me as an operator. And I just, I when I saw these results, I thought to myself, how am I going to, think about this as a physician, as an operator? And I thought, one of the few peoples on the earth that got unblinded was my wife, who's a physician. So I guess I'm allowed to do that. But she actually was the one who brought up with me. She said, well, if you're a patient, would you rather want to be sure that your stent's not going to clot off while you're walking in Costco? Or would you be more worried that you might have to have another stent down the line?
Well,
So,
that's the problem. That's the problem with composite endpoints. They weigh to death the same as an ischemia-driven revascularization. And I would urge you to do a win ratio where death is at the top, target vessel MI, stent thrombosis, the things that are most important, get weighted appropriately. Then at the bottom, if you didn't have those horrible things, then at the bottom you look at ischemia-driven revasc. I think you might see some surprising results there.
Yeah, I think that's a fantastic suggestion. That's why we have people like you to guide us, Mike. You've been in this game for a long time. So those are the results of Illumien 4. I think they're meaningful. I think they're impactful. It is the first global trial of intravascular imaging performed, and I hope that it impacts the field in a positive way.
I think it will. And the things that I like are that it was highly powered, 90 to 95% power. You hit the event rates you thought you would hit, so you adequately tested the hypothesis. You weren't underpowered. You did a very careful job with the blinded analysis of the OCTs to understand the why behind what you observed. So congratulations. This is why we do research. I was surprised. You were surprised. But this is why we do it. So Ziad, thank you so much. Great job. Excellent results. Great presentation. Thanks for joining us.
Thanks so much, Mike.
Thanks to all of you for joining us here from ESC 2023.